breast imaging modalities are many, and we would like to, ask our Dr. Mona Mehta very quickly about what's new in the mammography field. Can you go to the next slide or give me the controls, please? Yeah. So what are the recent advances in mammography and evaluation of breast after neoadjuvant therapy and the role of MRIs? So could you briefly, educate us on this?
Yeah. Ma'am, can you hear me?
Yes.
Okay. So as far as recent advances in mammography it is the introduction of the full field digital mammography with 3D tomosynthesis. Now, this technique utilizes low dose X-rays and obtains images of the breast in thin slices from different angles. So what we get in the end is very high resolution images of the breast in a matter of seconds. And the advantage of a 3D tomosynthesis is that it delineates margins of the mass very well. Architectural distortion is beautifully seen. And it is especially useful in patients with type C and D breasts, which are heterogeneously dense and extremely dense, because there is a lot of overlap of the fibroglandular tissue. If we have an attachment like of a biopsy, then it is possible with the 3D tomosynthesis to even biopsy, say, microcalcifications which are not associated with the mass. And even clips can be placed under mammography guidance. And of course, one of the latest innovations is the introduction of contrast-enhanced digital mammography.
Yeah.
And, as far as the second question is evaluation of breast after neoadjuvant, the main aim of imaging would be to define or to delineate the exact extent of the disease before starting the neoadjuvant chemotherapy. And how is this done? This is done with the help of mammography, ultrasound, and dynamic contrast-enhanced MRI.
I think you could show the slides, please. Can you advance the slides?
Yeah, so this, can you see my pointer?
Yeah, you can just say next, because the control is not with me. Yeah.
Yeah. So if you can see, this is a conventional 2D mammogram, and I'm pointing out to this particular lesion. Now, the margins of this lesion are not well seen because of a lot of overlap of the tissue here. So now, in contrast, when we do the 3D digital mammography with tomosynthesis, you can see the speculations extremely well on this tomosynthesis image. You can go to the next slide. Yeah. So the same here, this is a 2D image and this is a 3D image, and where the microcalcifications and speculations are extremely well seen. Next, please. Yeah. So this is again a lesion which could have been easily missed. Even if this is a digital mammography, this is a conventional, this is the 2D mode of the mammography, and this is the 3D tomosynthesis. So if you see, if you just look at the mammogram, you may not be able to pick up this lesion. But the moment we run the tomo slices, you can see the margins of the lesion extremely well, and they just stare at us, so we can really pick up these lesions very well on the 3D tomosynthesis.
So I think now I would just ask Dr. Megha Tandon that when you get a patient with who has received neoadjuvant therapy, how would you like to image that patient before taking up for surgery? So Dr. Megha Tandon.
Right, ma'am. So as rightly said by Dr. Mona, that we need to have some assessment before surgery. If the patient is going for neoadjuvant chemotherapy, we need to mark and clip the area before putting the patient on neoadjuvant chemotherapy. And we usually do a MRI to see the response. So we use the RECIST MRI, RECIST criteria to see the response after neoadjuvant chemotherapy. And then, of course, before taking the patient to surgery, we'll have to repeat the MRI and find the exact size, the response, and the clipped, and only the clipped area with margin we would be able to remove, and we should be able to preserve the breast if that's the case, if that's what patient intended, and that's why the patient was put on neoadjuvant chemotherapy. So whatever imaging modality was done pre-neoadjuvant should be repeated before taking the patient to the surgery.
So Dr. Mona, can you quickly show the 3 slides you had to show the response? Next slide.
No, ma'am, this is the slide which is showing that we have clipped and we have done a hook wire. And this is the specimen mammogram, which shows the hook wire in place and the lesion which is out. So next slide, please. This is an image which is showing the contrast enhanced digital mammography. That is one of the latest innovations in mammography, where we take low energy, low kV and high kV images of the breast. And the image which is obtained is this, where you can see that this particular lesion, which is just showing a rim enhancement. This procedure is done with the help of, you inject iodinated contrast just like a CT scan or an MRI. And in the end, what we get is an image which only picks up those areas which are abnormal and which enhance abnormal. So this is the contrast enhanced dynamic digital mammography that I've shown in this image. Can we go to the next one, please? Yeah, this is also another image where if you see that this is a 2D image, this is a 3D image. This 2D image shows this mass here in the outer quadrant of the breast. Here in the 3D tomosynthesis, you can see the speculations well. And once we have injected the iodinated contrast and done a subtraction image following that, this is how the lesions appear. So there's not only one lesion, but now this lesion was not seen anywhere on these breasts. So the contrast enhanced digital mammography helps picking up additional images. It's like just like a dynamic contrast enhanced MRI. And it is particularly useful for patients who cannot afford an MRI, who cannot undergo an MRI. For example, those who have a pacemaker or those who are claustrophobic, then this is a very good alternative to a dynamic contrast enhanced MRI.
Yeah. So thank you, Dr. Mona Mehta. Now we move on to the other part of diagnostics. Next slide, please. No, let's go to the next slide, please. Next slide. Next slide. No, next slide. No, I think, no, these are, yeah. So what are the diagnostic tests in breast cancer? So coming to the histopathology, HER2 testing, ER/PR, PDL, and other biomarkers. Now, coming to Dr. Gurudutt, who is our pathologist on the panel, I would like to straight away come to the HER2 testing. Dr. Gurudutt, are you there?
Yes, ma'am.
So I just want to know from you, what is new in the HER2 testing according to the ASCO-CAP guidelines, which are published in 2018? And then, of course, this concept of HER2 low breast cancer.
Ma'am, the new thing that happened was now it is advocated that first IC should be done, and they have divided it into 5 groups. So in first, if it is say HER2 3+ on IC, then there is no need for. You can
just move on to the next slide. I don't have the control. Yeah.
Yes.
Yeah.
And if it is group 5, that is negative, then you need not do it. So in between this 2, 3, and 4 groups, then you have to go for additional testing by FISH. So that is the, I think, the change for the ASCO-CAP 2018 update. So it has put IC in the center, and whenever there is a say a problem with FISH, then you have to take a call by considering the IC. So that is the change.
Yeah. And now coming to our medical oncologist, Dr. Krupa Bajaj, can you tell me what is this concept of low HER2 breast cancer?
So low HER2 breast cancer, in the sense, FISH, you are talking about the ratio, ma'am, or the 2+ you want to describe myself?
No, just move to the next slide, please. So this is what is HER2 low breast cancer.
Correct.
So could you expand on this, please?
Yes, ma'am. So it is usually called as 1+, either usually 1+ incomplete membrane staining will be there. That's a barely perceptible staining will be there in more than 10% of the tumor cells. It is 1+, it is HER2 low. Usually we don't tend to push towards doing FISH in this kind of patients, only when it's 2+, when there's dicey situation is there, when moderate staining at least is there in more than 10%, then we tend to do the FISH for this patients. But if it's an incomplete membrane staining, usually you don't get tempted to do the FISH in this patients. Those patients are called as HER2 low patients.
So it is 2+ as well as 1+. So 2+ FISH negative and 1+, of course, with more than 10% incomplete stain.
Correct.
That is taken as HER2 low, but the definitions are not universally accepted. That is the biggest problem with HER2 low.
Heterogeneity, yes, a lot of heterogeneity is there in this.
Yeah.
And in HER2 2+ also, the biopsy was proven as HER2 2+, which is negative. Usually most of the pathologists post surgery, they do repeat it, whether it's 2+ or 1+ again. So a lot of heterogeneity is there in 1+, 2+.
If it is on biopsy, then you should repeat on the resection specimen.
Correct, correct.
Swajit here, ma'am. Can I just put in a word? Because recently the Destiny 04 study got approval. I mean, they published the results, not yet approved. So because of that, we are now looking at this particular subgroup called the HER2 low breast cancer as a separate group, which almost forms 50% of the patients. Yes. And they are classified as defined in this algorithm. And in these patients, if you use trastuzumab deruxtecan, there seems to be actually a survival benefit. And this is proven by the Destiny B04 results, which got published 2 weeks back.
Yeah. So
as rightly pointed by Dr. Bishwajit Dubasi, even like 2+, 1+ also, they got a very good response. Even faint staining,
yes,
there's a great uptake is there. In TMH Destiny enrollment happened, I myself visualized 1+ patients also got a great response. Even the total shrinkage of tumor happened.
So the response rate was almost, in the initial thing was almost 37%. And the median PFS was almost 11 months. So that is what I was coming to. This entity has now become very prominent, and this is from a publication in 2020, where it shows that, what is meant by HER2 low. And as rightly pointed out by a medical oncologist, this has very good implications in the future for treatment of these patients. So we are expanding the armamentarium of patients who are, HER2 1+ and 2+, but FISH negative. And just go to the next slide, please. So you can see that these are all the potential therapeutic options. And as mentioned, that the antibody drug conjugates are the most promising therapies. And of course, you have some of the bispecific antibodies and vaccines also on the horizon. So I think we are looking at a very interesting aspect. Now, next slide, please. Next slide. Yeah. Now, coming to the next one is that the PD-L1 testing. So, Dr. Krupashankar Bajaj, Dr. Krupashankar, are you there?
Yeah.
Dr. Krupashankar? Okay, then Dr. Biswajit, are you there? Yeah.
Yeah. So for the PD-L1 testing, so the immunotherapy drug has got approval in early breast cancer with the Keynote study. But in the Keynote study, it is irrespective of the PD-L1 testing, and the approval is there. So I'm not sure whether for early breast cancer, I would still want to do a PD-L1 testing. You could do, because the responses will be much higher if your PD-L1 is high. But irrespective of the PD-L1, the approval is there. Whereas for metastatic breast cancer, in the first line, when you use the drug pembrolizumab, then you need to have a PD-L1 testing, because the score has to be more than 10, then the benefit is there. So probably in metastatic breast cancer, definitely you would do a PD-L1 testing. In early breast cancer, may or may not be required. And if you are doing the test, then it will be the companion diagnostics to the pembrolizumab, which is the 22C3 testing. And are the tests concordant? There is clear-cut evidence that it is not concordance. You need to do the diagnostics depending on the drug which you are using. For example, atezolizumab has a different antibody, and you have a different antibody for the pembrolizumab.
Yeah,
I would like to add here, ma'am, one thing.
Yes.
So usually Ventana platform, DACO platform, for pembrolizumab, it is a IHC 22C3 we have to use. But the DACO is the standard one. Whereas for this SP142, Ventana is the standard machine. So if you see most across the world, like most of the people, even our own centers like TMH or Basatarka, we are having Ventana platform. So actually the paper is going to come, the standardization for SP142, yeah, IHC 22C3 on Ventana also. The paper will be coming soon next month. But most of the centers like tomorrow, even TMH, they used to use 22C3 on Ventana platform, but not DACO platform. There, its purchase is like much slower. Even in our center also, that's the same condition. And decent concordance is there. Even people who are not having IHC 22C3, they're doing with SP142 only, even for pembrolizumab. Even the early breast cancer, whatever you're saying, sir is saying.
Yes.
So other also.
So Dr. Gupta, what do you have to say on this?
Ma'am, I think for Pembro using SP142
Just go to the next slide, please.
Not a good idea, because what we have seen in our experience, SP142 is, I mean, like in our experience, we have done around 52 TNBCs on SP142 for Atizo, and the positivity is around 27% at 1% and above. So taking it for CPS is a bad idea. SP263 is better if you want to use it for CPS, though it will score it higher. But 22C3 or as a LDT done on Ventana benchmark ultra, it gives quite a good concordant results. That is our experience.
Yeah, so, sometimes it has been asked. Of course, now the question doesn't arise because in the metastatic setting, the atezolizumab study, they have, withdrawn it in the US market. And of course, it's still existing here because of the discordant results of the two studies. So, some people have asked, have you ordered for both the tests if one is negative? But I think now that question is settled because I want to know from Dr. Dubashi that if you had both the options, which drug would you go for given the results?
In the metastatic setting, madam?
Yes.
Yeah, I mean, currently there is no doubt because of this confusion of two trials showing contradictory results that they have withdrawn the label for the atezolizumab. So now the drug which is available is only pembrolizumab, and if you have a CPS score more than 10, then you could use the drug.
Yes,
so that is
right.
And this data is very clear that actually you cannot interuse the at least for the atezolizumab, the data was very clear because they did all the concordance this thing on test on the IHC by different techniques.
Yeah.
And they have clearly shown that if you actually interchangeably use it, your outcomes are different. Actually, the SP142 will have a lesser positivity rate when compared to the others. But when you actually look at the response rates, they found that only with SP142, it actually correlated with the response. So you actually cannot interchange and use.
Can you show the next slide, please? Next slide. Yeah, next slide. So this is, as you said, that, the overall percentage agreement is at subpar. So let's move on very quickly to the next question. Yeah, please go ahead with the next slide, please. Yeah, so now we have dealt with the IHC testing. We have dealt with, also the PD-L1 testing. Now, Dr. Kakoli, is she there? Is she there, Dr. Kakoli?
Yes, ma'am, I'm here.
Yeah. So what other testings do you do in, not in early breast cancer, but in metastatic setting, as far as the biomarkers are concerned?
Yes, ma'am. So we generally do, BRCA1 and 2 we do almost for all germline BRCA1 and 2, almost for all patients. And PIK3, generally I reserve it for second line most of the times. I generally don't do it upfront. Other than PD-L1, that is. And MSI, well, it actually depends because it also gives an indication of a hereditary Lynch syndrome. So that is one aspect for which we are doing. Otherwise, therapeutically, I do not really use it. So these are mostly these are the tests, and Ki67 is because we have to keep that ABEMA data in mind. So Ki67 anyway is done on the biopsy. So that we keep that in mind. Ki67, PD-L1, BRCA1 and 2. So mostly this, and of course, if the patient is affordable, then we in breast and lung we generally ask for NGS.
Yeah, so I'll come to that in the end about the controversy regarding NGS. But let's get on. Next slide, please. So this is just to do with the PIK3CA mutation. So when would you like to do it, Dr. Kripa Bajaj?
Yeah, ma'am. Usually, though the guidance suggests the first line is enough, like the PIK3CA is a standard mutation, it will not get mutated. It's once it is there, it is there. So usually post CDK4 inhibitor, 4/6 inhibitors, we tend to use it, not in the first line itself. Because it's always better to use post CDK4/6 inhibitor. We are not going to do this in the first line, alpelisib, so we do use it later. If the tissue is available, then we'll do on tissue. If it is not there, then we'll go for ctDNA.
So Dr. Biswajit, would you do it on tissue or plasma, or how do you go about?
Tissue is the gold standard, ma'am. We'll do it first on the tissue. With the plasma, the problem is if it is positive, it is okay. If it is negative, you cannot rule out mutation. So you have to do a biopsy after that.
Yeah, next slide, please. So this is about that 40% of hormone receptor positive and HER2 negative have PIK3CA mutations. And now I would like to come to Dr. Gupta. Which is the technique that you are using or the platform for doing this? You're muted. You're muted, Dr. Gupta.
Yeah. Ma'am, we use TheraScreen.
Yeah.
Kaizen. That is used for FDA approved kit is used for reporting the PIK3CA.
Yeah. So just go to the next slide. There are some interesting data about. So this is what Dr. Biswajit has said. So I think we can just move on to the next slide. Now people are doing NGS, though, as was mentioned in the AB6 guidelines, of which I was a part, that NGS should not be routinely done in breast cancer. But this is a study which looked at PIK3CA mutations which are picked up by other techniques other than TheraScreen, which has only 11 hotspot mutations.
Yes.
And you can see that there are other mutations which are detected. Now, actually, PIK3CA studied in the 11 hotspot mutations seen in the TheraScreen study. So the question does arise that if you do an NGS and then you pick up another mutation not in the 11 hotspot, then what do you do? Well, I have spoken to the company also, and they said that at the moment it is approved for these 11 hotspot mutations, but they are not asking for which mutation the patient is having. So even if you have other mutations on the NGS, you could still use the drug, though you don't have the data on that. So this is what it is. Next slide, please.
Ma'am, sorry to interrupt. Last 5 minutes to sum up.
Yeah. This is now quickly coming to the genomic studies. So you have this situation of hormone receptor positive, HER2 negative breast cancer, and go to the next slide, please. So how do you take the treatment decisions? Do you use it with something online? Of course, you know that adjuvant online is no more online, so you can forget about that. But I would like to know from Dr. Kakoli, how do you solve this issue?
Generally, ma'am, Generally, we ask for, either the EndoPredict or the Oncotype DX, and for patients who are not affordable, we have one Can Assist in India. From a practical perspective. So that's the one we ask, and we generally base the decision on Can Assist. If for some reason the patient is not willing for the test, then we take the other factors into consideration, age and Ki67 and percentage of ER positivity and all that.
So when I said Predict, it is actually an online NHS tool. So Dr. Kripa Bajaj, could you expand on that? Because that's a very useful tool since adjuvant online has gone offline. Yeah.
Yes, ma'am. It actually includes the age as well as tumor size and Ki67 index and everything. So usually we used to a lot about it, but later we declined ourselves to the clinical factors. If patient is insisting, later to the Can Assist or Oncotype DX, as my colleague Kakoli suggested.
Yeah, Dr. Dubashi could just say a few words and we quickly move on to the next part.
So I think what is approved are only two tests for predictive thing. One is only Oncotype DX is the only one which is approved as predictive for change of therapy. Whereas the rest of mammoprint and all that is only for prognostic. and it's not approved.
Yes.
And second thing is IHC4 again is it's not approved because it's not validated properly in the Indian setting. So only thing, if you're using, we should use Oncotype DX. That's number one. Second thing is, in what I do in practice is, if I have a patient who is more than 70 years, then and is luminal A or luminal B, then I would straight away discuss with the patient, use the Predict Online and see the benefit of the therapy in that patient, and then straight away go for hormone therapy. If somebody who is less than 70 and is luminal A, which is Ki-67 less than 14, and cannot afford Oncotype DX, otherwise, if they can afford, definitely Oncotype DX. If they cannot afford Oncotype DX, then the patient can take a decision again whether will require chemotherapy or not. Otherwise, for all patients, based on just clinical factors, it's very difficult to decide which patients to avoid chemo and which patient to avoid hormone therapy.
Of course, this population is very small. It may be around 15% of our patient population who would require this decision making. Next slide. Next slide.
Most of our patients, like usually,
so this is what it is. The luminal 65%, but you can go by classical features as well and use genomic tests in only certain patients. Next slide. Yeah, next slide. Yeah, next. So this is what it is. Now coming to the, this is how you can use these genomic tests. Now quickly moving on to the last bit, and that is about hereditary cancer. Next slide. So who should be tested? So can Dr. Kakoli tell me? Very quickly.
We generally test all triple negative, and hereditary means mostly, I am assuming you're talking about BRCA member 1 and 2. Yes. So, and hormone positive, whoever is eligible for olaparib. So we test in these patients.
So when do you test? Yeah.
Yes, we test it at diagnosis. We generally test it at diagnosis nowadays. And most of the times we are using targeted testing, not a multi-gene panel, and germline usually till now in breast cancer.
So Dr. Dubashi, what do you have to say? And Dr. Kripa Bajaj?
60 years for TNBC, less than 50 years for the hormone positive to get tested for the BRCA test. And if the strong family history is there for other thing, the other cancers like them.
Yeah. So next slide, please.
Always germ and the somatic.
Yeah. So if you look at the indications here in the GNA panel, as mentioned in the NCCN guidelines, it is almost encompassing all patients, and it's only above the age of 60 or likely to get, like in hormone receptor positive or the HER2 positive, you are less likely to get a positive test from this, but otherwise, it's expanding. And anybody using the multi-gene rather than targeted?
Ma'am, just for the testing, the only thing we should keep in mind that we could use NGS also for testing, but also we should remember that if anything comes negative, because some of those mutations are very large, they can be missed on doing targeted ones. So then we need to do an MLPA. So we should do an MLPA along with an NGS. That's a valid way of testing.
So that is very important, that you can't happen to miss. So in that case, you would need to do an MLPA. Next slide, please. Next slide. Do you rebiopsy in metastatic setting? And how much is the discordance? So Dr. Kripa Bajaj?
Yes, ma'am. Whenever patient is on long-term hormone receptor for MBC, for first of all, patient is doing well for 3-4 years on hormone therapy, later started progressing, and then we try to tend to do whether there is any change in the receptor status or not. So usually, yes, ma'am.
So, it is seen in about 10 to 15% of the patients either losing the ER receptor or the HER2. Now, how do you deal with that situation, Dr. Dubashi?
As rightly said by Dr. Kripa, that we do it for hormone positive mainly because positives become negative more commonly rather than negative becoming positive. And in that situation, then I would not consider putting them onto an hormone therapy and would give them chemotherapy probably and not put them onto hormone therapy. It has happened sometimes. We have had strong positive or hormone positive, but on relapse metastasis they are negative, and we put them onto chemotherapy.
So just look at the ABC6 guidelines. Next slide, please. Next slide. Please show the next slide. So if there is a difference, it is currently unknown which result should be used for treatment decision making. Since a clinical trial addressing this issue is difficult to undertake, we recommend considering use of endocrine therapy or anti-HER2 therapy respectively when ER or HER2 are positive in at least one biopsy, regardless of the timing. So I think as far as HER2 is concerned, even if there is a loss, and we know that if a patient has received neoadjuvant anti-HER2 therapy, if in the residual tissue, you may get HER2 negativity. So in those patients, you should use the anti-HER2 therapy. And as far as ER and PR is concerned, you could go for chemo first and then, but later on maintain with hormonal therapy. Next slide. Am I out of time, or now this is about, you know, the ER.
You need to conclude, please. We are running short of time, please.
Yes. So ER negative, PR positive, how do you treat those patients? Dr. Kripa Bajaj?
Yes, ma'am. We do actually ER negative, PR positive, it is strongly positive. Better to introduce CDK4/6 inhibitor in the beginning itself. And in this subset, abemaciclib has proven some benefit compared to other. It is not different in the maintenance or whatever it is a visual crisis. It's not different from ER positive compared to PR positive. We do give the same maintenance for them also. But if you want to introduce hormone therapy, then better to add with the abemaciclib than other CDK4/6 inhibitors.
Yeah, but as mentioned, you know, it should be actually treated. These are only 5% or less than that. And according to the guidelines, these patients should be treated as actually triple negative.
Negative though.
Yeah, I think this is the last slide. I just want to ask Dr. Gupta, is this really possible or it may be a lab error?
Ma'am, it happens sometimes. We get 2 to 3% such cases where PR is only positive. But usually PR, very few cases we have seen, I mean 2 or 3 where PR was more than 20%. Otherwise, it is 5%, 10%. I think that those cases should be taken as negative only.
Yeah, actually the last 2 things I had to discuss was, you know, the use of liquid biopsy and NGS. But since both of them are not established and, you know, they are only on the horizon, especially the only approved is the PIK3CA mutation, but we do not use. Are you using ESR1 mutation analysis anytime, Dr. Dubashi?
Currently, no, ma'am. Except that interesting study of that PADA study which came up.
Correct.
Interesting. So otherwise,
yeah.
No.
That, you know, they're randomizing those who are on the aromatase inhibitors with the CDK4/6. If they have an ESR1 rising, then they would change the aromatase inhibitor to fulvestrant. So that is an interesting study that we have to look forward to. So I think with this and NGS, as I mentioned, and it was mentioned in the ABC6 guidelines as well, should not be done routinely. And, you know, it is only in certain circumstances. And there was this study presented by Andrew Fabrici in the SABCS just concluded, where he showed that only if the SCAT1 and 2 actionable mutations are found, that it has any benefit to the patient, and that too if you have the actionable drug. But otherwise, it is of no benefit. Do you agree, Dr. Kripa Bajaj?
Sorry, ma'am. I just lost your voice. Actually.
The NGS. NGS.
Yes, ma'am. Yes, ma'am.
Yeah. Do you do NGS?
Yeah. No, I never suggest NGS, ma'am. Only in TNBC patients, when patients are very enthusiastic, foundation test, they do opt, but we never suggest to do NGS.
So I think with that, I would like to thank all the panelists and also the organizers for giving me this opportunity. Thank you.